So what I'm going to talk about over the next couple of minutes is the following. I'd like you to come away with the appreciation of the impact of delirium in palliative care. Then I'd like to tell you the story of a patient that I met some time ago. And I don't know about you, but I learn so much from the patients and their families that I meet. It's one of the parts of the privilege, the things that contribute to the privilege of what we do. Then I want to talk more specifically about the diagnosis and how we manage people with delirium. Then I want to just offer a few comments on how we might think about preventing this problem in the patients that we see. And then finally, just review for you some of the elements of a clinical practice guideline that we've developed in Calgary to try to help us to deal with this difficult problem. Well, as I mentioned, it's common, and as you told me, it's very common. Up to 85% of cancer patients will have a delirium at some point in their disease. A large proportion of patients with cancer who are hospitalized have delirium. So not surprising that most, if not all of you, have encountered this recently. This is a distressing problem. It's distressing for patients. It's very distressing for family members. When you have the wife of a delirious patient say to you, completely oblivious to the fact that her husband was confused when he said it, you know, yesterday he hit me. In 35 years of marriage, he's never so much as raised his voice, and yesterday he hit me. She had no insight into what was going on, that this wasn't him doing that voluntarily. Very distressing for her. For we as healthcare providers, also very distressing. In fact, there is in the literature documentation of something called a destructive or pathological triangle, in which the family member goes to, let's say, the bedside nurse and says, "Dad is really distressed, you've got to do something." The nurse calls the physician, and the physician doesn't react in a helpful way, but that doesn't ever happen in Saskatchewan. And doesn't empower the nurses to do the appropriate thing to help the patient, and consequently, the family member, the nurse, and the physician get in what's called a destructive triangle. Very distressing. It's a burden on the healthcare system. This accounts for a significant number of visits to the emergency department, admissions to hospital, and resources required to support families. When we assess all of the other symptoms in palliative care, Dr. Black's going to talk to you about pain this afternoon. When we assess pain, we rely so much on what the patient tells us about their pain story in order to learn what might be causing their pain and how best to manage it. If our patient is confused and unable to give us a reliable story, we're immediately hampered in our ability to assess their pain or other symptoms, and consequently managing their symptoms effectively is decreased. Perhaps it wouldn't be quite so important if there wasn't something we can do about it, but in almost all cases, delirium can either be prevented or at least managed. And finally, there's good evidence to show that we in healthcare don't do the best of jobs here. We tend to not recognize delirium as often as we should, and we tend not to manage it appropriately very often as well. So lots of room for all of us to improve the care of our patients in this way. Well, let me tell you about a man that I met some time ago. Mr. D, as I'll call him, was 68 years old. He had a 6-month history of lung cancer, and about a month before I met him, he had been diagnosed with having some metastases in the body of his 3rd lumbar vertebrae. He had no other significant medical problems. He was actually doing quite well. He was stabilized on sustained-release morphine, 30 twice a day, hardly ever used any breakthrough morphine. He was on naproxen, a nonsteroidal anti-inflammatory, on a regular basis, and an appropriate bowel routine. He was living with his adult daughter and her family, and his wife was there as well. They had moved in after his diagnosis with cancer, and actually things were going very, very well. Going well, that is, until 5 days before I was contacted. I was contacted on a Friday afternoon, and it's often when these things happen, isn't it? And the story was as follows. On the Monday before, he had required 4 breakthrough doses of morphine, which was unusual for him. As a consequence, the healthcare providers looking after him had decided to increase his sustained release morphine from 30 to 45 twice a day. Still, he needed 8 breakthrough doses of immediate release morphine, so that on Wednesday, they increased his sustained release morphine to 90 twice a day. And because he used so much breakthrough on the Thursday, they increased it yet again to 190. Despite the fact of this elevated dose of morphine, he used considerable amount of breakthrough through the course of that day, so that on the Friday, they had to increase his sustained release morphine to 300, which was now exactly 10 times what he was on the Monday before. They also noticed that on the Thursday he was a little bit agitated, so they added some lorazepam or Ativan. And when I asked them whether he was eating and drinking properly, they thought maybe in the past few days, not quite so much. On the Friday, in addition to the morphine and Ativan, they noticed that he was complaining of 10 out of 10 generalized pain, and that 60 milligrams of immediate release morphine made no difference to his pain whatsoever. The patient was becoming argumentative, verbally abusive, completely uncharacteristic for him, and his wife and daughter were very, very distressed at the pain and the extreme physical suffering that he was undergoing. All in the home were desperate for help. So I went and did a house call at his daughter's home. I was greeted by 3 generations, wife, 2 daughters, grandchildren. They were about 2 feet from my nose as I walked over the threshold. And it was a feeling of desperation that I think many of us have when patients or their families are so eager for help because of the level of distress that they have. Interestingly, after a few minutes of listening to their story and getting a few more details of this agitated, restless, angry, argumentative man, I walked into his bedroom. He looked relaxed, perhaps a little bit drowsy. He greeted me as if he was expecting me. "Hi, Doc." And he was quite pleasant. So the question is, why is the story that I got from the home care nurse and the family different from the patient that I'm seeing in front of me? Any comments? Think about that one for a moment. Well, I went on to do a little bit more. He didn't appear to be in pain, but when I asked him, he said he had pain all over, and his pain was 10 out of 10. He confided in me that he thought his daughters were conspiring to kill him, so he was paranoid. And when I asked him 3 questions, he answered yes to all 3. I asked him about the following types of hallucinations. I said, "Mr. D, are you seeing anything unusual here in the room? Things that don't belong here?" And he said, "Yes, my cat's been sitting on the end of my bed all afternoon. And my cat's been dead for 3 years. And it was as a matter of fact as can be." So he was having visual hallucinations. I said, "Mr. D, have you had the sensation in the last few days that there's something touching your skin or something crawling on your skin, and then you look and there's nothing there?" "Well, yes, as a matter of fact, I have had that experience." And he was able to explain that quite specifically to me. So he was having tactile hallucinations. And then finally, and this is a common one in this type of delirium as well, Mr. D, have you had the experience that you were convinced there was someone else in the room with you, and then you turn and look and there's no one there? And he looked at me as if to say, yeah, how'd you know? Very common to have that sensation of someone else in the room with this particular type of delirium. So those 3 types of hallucinations were all present. Interestingly, when I asked him what day it was, what month it was, and what season was, he was a little bit confused, but he knew exactly where he was. He remembered who I was, and he could identify his daughter sitting next to me. So he was oriented to where he was and to the people around him, a little bit confused about time. When I went on to do another exercise, something called the Folstein or mini mental status exam, there were some concerns. How many of you are familiar with the Folstein? Most of you. His score was 19 on 30, probably abnormal. I would have called 24 or greater out of 30 normal for this man. So it was abnormal, and as I began to do it, he did complete it, but he became progressively more anxious. I also noticed that he looked dehydrated. I noticed that he was a little bit tender over L3, and then he also had 2 other findings. He had hyperalgesia and myoclonus. Hyperalgesia is when a person responds in an excessive way to a painful stimulus. So if I would have poked him with a pin very lightly, I might have expected him to say, yes, I feel pain, but he would jump. So an increased response to a painful stimulus. But he also had something called multifocal myoclonus. How many of you know what that is? Can somebody tell me? Involuntary muscle jerking, thank you. So when you see a patient who's kind of jerks a shoulder, jerks a leg, another involuntary group of muscles jerking over time, that's probably multifocal myoclonus. So we had that as well. Well, we decided to admit him to hospital because we thought that the kind of treatment he needed probably deserved hospital care. And even more than that, his family simply was too distressed to be able to look after him any longer at home. Dehydration and opioid toxicity would top my list as well. Well, here's what we did. We rotated opioids, so we stopped his morphine, and we put him on some hydromorphone. I'm going to ask you in a moment how much hydromorphone you would put him on. Remember, he was on 300 of morphine twice a day. So the physicians and the pharmacists in the audience might want to think about what they would do in a situation like this. We gave him some subcutaneous hydration because we too thought he was dehydrated. And we also know that opioid toxicity is believed to be caused by opioid metabolites that are excreted by the urine. So if we hydrate a person, we promote the excretion of those offending metabolites. And we also put him on some haloperidol, both a regular dose and an as-needed dose for agitation and restlessness. Hydromorphone would be appropriate. Anyone? 60 milligrams twice a day? Okay. Any other suggestions? 30 twice a day? Okay. So you're taking hydromorphone to being 5 times more potent as morphine, milligram for milligram, and then either using that or reducing the dose by a proportion. I'll come back to that in a moment. We also did a little bit of blood work. He had normal electrolytes. His creatinine and urea were up, suggesting he was in fact dehydrated. Otherwise, his blood work was normal. His calcium was normal. His urine was clear. There was no evidence that he had an infection in his urine or in his lungs. Well, he continued to use a fair bit of haloperidol because of agitation, which actually got somewhat worse in the hospital. And we were forced to use something called methyltrimeprazine, or Nozanan. Some of you may be familiar with this. It is somewhat more sedating than haloperidol, And we often use this medication when Haldol is not enough to settle the restlessness and agitation. He was somewhat better 2 days after being admitted to hospital, so this is now a week after everything started. A little bit confused, but certainly less agitated since he was on, because of being on the Nozanan. By day 10, so 5 days after being admitted to hospital, his mini mental status exam was 28/30. He was much less agitated. He was only on a very small amount of Haldol. No longer needed any Nozanan. His pain was very well controlled on hydromorphone, 2 milligrams every 4 hours. How much morphine is that equivalent to? 2 milligrams would be the equivalent of 10 milligrams Q4, or 60 milligrams a day, or 30 milligrams twice a day, which is what he was on for several weeks before this whole adventure started. Think about why that might be. He stayed in hospital for an additional 16 days, even though his pain was well controlled, his delirium had resolved, and the single reason was that his wife, and particularly his daughter, needed so much support by our social worker on the team to be convinced that they could look after him again at home. The experience had been so distressing for them. He lived another 3 months at home under the care of his daughter, and did very, very well, with considerable support with his family, by the way. Well, let's use the experience of Mr. D to talk a little bit about delirium. Yes? So the question is that if he ended up on the same amount of analgesia after his delirium cleared, what made him need so much morphine during the course of that week? Was that your question? What started the pain increase on day one to begin with? That's the critical question. Does anyone want to offer an answer? The emotional pain of the patient and the family. An obvious possibility, I would agree. Any other, and you're partly right. And I'll give you a little bit more on the story in a bit. Other possibilities. Well, the punchline, if you will, for this story, because we were intrigued and had the same question. Why was it that he stabilized on the same amount of opioid in the end after his delirium had cleared? The first part of the answer is that we know there is good evidence that during a delirium, patients make us think they have more pain than they do. A good study that was done in Edmonton some years ago showed that during a delirium, a person's pain scores and analgesic requirements go up, and then as the delirium clears, their pain scores and their analgesic requirements return to baseline. So something is happening during a delirium that makes them, their family members, and all of us think they're having more pain. And what do we do when we think a patient has more pain? We give them more analgesia. And in this case, we probably were pouring more fuel on the delirium fire. So we talk of delirium masquerading as pain. So if the first take-home message of today was delirium is common, the second take-home message is it often masquerades as pain. So when you first encounter someone with pain, you need to get an idea of what their cognitive function is and whether or not delirium is hiding behind that mask of pain. But I still haven't given you the whole answer, because what was it on Monday that either gave him more pain or tipped him into a delirium? And we couldn't figure it out until his delirium cleared. And then I asked him, and he just gave me the answer. I said, what was it on Monday that made you need more morphine? Well, what had happened was that his eldest daughter had looked after him up until the Sunday. For 4 weeks she had taken time off, and then she had to go back to work. In came his second daughter. His second daughter had some issues. She had a lot of things in her life suggesting that she was very codependent. And I won't go into the details there, but when she took over his care on the Monday, he said that she just kept coming back to me with the morphine and saying, "Dad, you're in pain, you need to take this morphine." And in his words, not mine, he said it became a lot easier to take the damn stuff than to put up with her nagging me. So what had happened is he probably was in a little bit of a precarious balance with respect to his opioids to begin with. She gave him an extra 60 milligrams of breakthrough, that 40 or 60 anyway, so probably 70 to 100% over what he was taking to begin with. And that started the delirium cycle. And then, of course, he got delirious, he complained of more pain, and then their response was to give more morphine. So the answer was delirium masquerading as pain and some family emotional distress. In this case, one of the daughters that I think was projecting her emotional pain onto her father and wanting to treat it with opioids. Interesting lesson for us all. Certainly was for me. So to talk a little bit about delirium then, we talk about it being, and I'm going to use the DSM-4 classification here to summarize it for you. First of all, a disturbance in level of consciousness. And we often think about delirious people as being agitated and restless, so they tend to be more alert and they won't settle at night. But it's also true that they may be sedated or have a decreased level of consciousness. And we tend not to think about those people because they're not the people that call the nurses and the doctors or cause distress in such a way. They also have difficulty focusing or shifting their attention. And if you ask someone, "Do you know what day it is?" and they say Wednesday, and then you say, "Do you know what season it is?" and they say Wednesday, you can sort of sometimes overlook that, but actually it's a subtle early sign of delirium, difficulty shifting their attention. The second thing is that they have disordered cognition. They tend to be confused, and sometimes it's quite subtle, and we're going to talk about that in a moment. The other thing is they have disordered perception. They may have hallucinations, they may have paranoia, and so on. The third characteristic of delirium is that it usually develops over a short period of time and the symptoms fluctuate. And notice this, remember the story I got of Mr. D from the home care nurse and the family. This picture of an agitated, argumentative, difficult man, and I walked in, he was pleasant, maybe even a little bit sedate. So the fluctuating course can be quite misleading. We as healthcare providers tend to see our patients for quite short snippets of time, whereas their family members see them often over 24 hours a day, and they can witness these fluctuations, and we can become fooled because we see them when they perhaps are less severe or in a hypoactive cycle of their delirium. The other thing that confuses us with the fluctuating nature of delirium is that sometimes we see them when they're agitated or restless, and we give them something like lorazepam or Ativan, and then an hour later they go into a hypoactive phase, and we think, boy, this Ativan's just the greatest stuff. And it's probably not the Ativan. In fact, we're going to talk a little bit later. Ativan may actually contribute in some cases to their confusion and delirium. So that fluctuating course can really confuse us as we try to care for these people. And as I mentioned, it tends to develop over a short time as opposed to dementia or other more chronic conditions that can cause cognitive dysfunction. And then the last criteria is that usually there should be evidence or at least a suspicion that there's an underlying physiological problem that's causing their brain to fail. Other features that are important to think about is problems with their sleep-wake cycle, and this is often one of the earliest things that will call a delirious patient to our attention. The family may say, you know, for the last 3 nights, he's just not sleeping very well. He's up and around, wandering, restless, quite difficult to settle. Disturbed psychomotor behavior, agitation I've mentioned, but also hypoactive, decreased psychomotor behavior can also be a feature in some people. Emotional disturbances can sometimes really confuse us. Often we attribute delirium falsely to anxiety, to fears about death and dying, to panic attacks, and so on. And all of those need to be considered, and sometimes we misinterpret one over the other. And labile emotions are often observed as well. But the last feature comes back to our patient, the issue of crescendo pain, and I've already talked about how delirium can masquerade as pain. Let's talk a little bit more about that. I've gone into that on how we tend to confuse this, how pain scores and analgesic use increase during a delirium typically, and then can return back to baseline. The other thing I want to mention is that the evidence suggests that when you have a patient who is both delirious and complaining of pain, it can be very difficult to control that pain, whether or not it's true physical pain or pain as a result of delirium, unless you control the delirium first. So it's almost like delirium trumps pain. Think about how difficult it would be to persuade a family that it's not more morphine their loved one needs, but either investigation or management of their delirium. It can be quite challenging. Hyperactive delirium is that delirious patient that we tend to think about first, that one that rings the bell, that one that's in the hospital near the desk at night because they're causing a disturbance. The hypoactive patient is the one that all of us tend to overlook. They're the one that just sort of lie there. They may not say much. They may be, in fact, they may be completely, they may not interact with anyone at all. And we tend to miss them. We tend to assume that they are either depressed, withdrawn because they have a terminal illness. There used to be a term called cocooning. I don't know whether any of you are familiar with that. And I suspect that and it was thought that they were simply just withdrawing as a result of a diagnosis of a terminal disease, and they were preparing for their death. And almost certainly these people had a hypoactive delirium. The important thing for all of us to realize is that evidence suggests that for the patient, the hyperactive agitated delirium and the hypoactive delirium are equally distressing. So when we say a patient is pleasantly confused, it means they're confused and we're pleasant about it. And we need to be just as aggressive in managing their delirium as we would be with the patient that really distresses us and their family, that is the agitated hyperactive delirium. And of course there can be those who have a mixed delirium and fluctuate between those two extremes. Well, delirium can be very challenging to diagnose. It's challenging because of the variability of symptoms. Different patients present with a wide range of symptoms, the variability of signs, and the fluctuating course, which I've mentioned. We often confuse these patients as having another problem: dementia, depression, a psychosis of one type or another. So very important to think carefully about what might be going on in patients that we have assumed have these disorders. It may be delirium. When it comes to assessing these patients, early detection is very important. One of the things that's difficult for us to understand is and appreciate is that often we miss delirium if we simply use our clinical judgment alone. Walking in, hi, how are you? Do you know where you are? Do you know what day it is? and they're eating, they're drinking, everything's going well, there's evidence to suggest that we miss delirium in 50% of the cases if we don't use some sort of screening tools. I've mentioned the Folstein exam. There are others that are out there. The advantage of the mini mental status exam is that it's been validated in cancer patients, and also it's reasonably well known. It's used in geriatrics, it's used in a number of other areas in healthcare. So generally speaking, people are at least familiar with it, if not trained to use it. And the other thing is it's pretty quick. Once you become well versed in it, it's probably an average of 4 to 6 minutes to administer it. And the advantage is that you can pick up a patient who doesn't otherwise look delirious and identify them earlier on and hopefully reverse the course before we have a story such as Mr. D. And if someone would have done an MMSE on the Monday, it almost certainly would have been abnormal. And if it wouldn't have been abnormal, it would have been decreased over his baseline. In other words, if they would have done a baseline a month before or when they admitted him, they would have found that he likely was 28 or 30 or greater, because that's what he ended up being, 28, 29 out of 30. And if they would have found him to be 26 out of 30 on the Monday, they might have thought, oops, there might be delirium at work here, and they might have thought a little bit about what might be going on aside from his pain. The other advantage of an MMSE is you can use it to monitor the progress of the patient, as we did in this case. So we knew that he started off with 19 on 30. He actually got a little bit worse the first 24 hours or so because of his agitation, and then he very quickly returned to the normal range within a few days. I think I've talked about most of the advantages of the MSE. There are some limitations. Remember that it only screens for cognitive impairment. So I find it very useful to ask questions about hallucinations. And in opioid-induced delirium, particularly those about visual and tactile hallucinations, and that question about have they thought that there was someone else in the room with them when there was not. Well, we talked about what was causing potential causes of delirium in our patient this morning, and certainly dehydration and opioid toxicity were the two that seemed to be contributing to his problem. We also considered other medications that he was on, and I've mentioned lorazepam. Benzodiazepines are a frequent cause of delirium. But don't overlook other medications, anticholinergic medications. So many of the neuroleptics, including Haldol, have anticholinergic effects. Tricyclic antidepressants that we sometimes use for neuropathic pain and other problems have anticholinergic effects, and so on. Medications are probably the most common reversible cause for delirium that we encounter. Infection, urinary tract infection, and respiratory tract infections would be the most common. Metabolic changes, renal and hepatic failure, hypercalcemia, electrolyte disorders, particularly hyponatremia, all very common. Won't go through this whole list except to say that alcohol withdrawal is probably more common than we appreciate, and we likely overlook it in some of our patients. So something to think about when you encounter a patient with a very agitated delirium, particularly with hallucinations. Well, when we talk about appropriate management for patients with delirium, there are many different things that we need to do, and I tend to divide them into the non-pharmacological and the pharmacological. And I've deliberately started with the non-pharmacological because I think I often overlook how important it is. And I want to focus, I'm not going to go through the whole list, but I want to focus on the last point on this slide, education for family members. I've already said just how distressing it was for this particular patient. And I think it's very helpful, at least I find it so, to give quite a detailed explanation about what delirium is to family members. I talk about how, and I use the word delirium, and I say that's a medical term for a condition in which the brain is not functioning normally. And it's not functioning normally because it's not getting enough oxygen, or it's not getting enough blood flow, or it's having toxic effect from these medications, or the patient has an infection, and so on. So I try to convey the message that the brain is sick. Just as we would talk about someone in heart failure, liver failure, kidney failure. Then I try to link what they are experiencing with the fact that their brain isn't working. So I talk very deliberately or very explicitly about what they're seeing. So, you know, when he was accusing you of killing him, that's what we call paranoia, and it's common in delirium. That wasn't Dad. That was his brain not working well. You know, when he tried to hit you, that was because he may have been hallucinating, and he may have thought that you were somebody who was trying to do something nasty to him, or he may have seen a frightening image that he was actually taking a swing at instead of you. I talk about how if you could imagine not being sure where you are, not being sure what's going on around you, and being very, very frightened, how you might react in such a situation, and really try to give them a sense of what their loved one is experiencing. I think it's important because they need to be able to interpret what they're seeing appropriately, and certainly don't want them to misunderstand that it's something that they've done or not done that's provoking the behavior in their loved one. The second reason why I think it's important is I want them to be a part of helping to manage the patient. I want them to try not to create a noisy, overstimulating environment. I want them to appreciate that having the ghetto blaster on and the television on and a couple of people having a conversation over the patient's bed, a situation that I would find kind of confusing and overstimulating, might be very distressing to a delirious patient. I also want them to appreciate that when the patient becomes agitated and complains of having pain, that the nurse may not bring more morphine. The nurse may bring Haldol or some other medication to try to decrease their restlessness, and that that's going to be more effective than bringing more morphine. So I think very important to spend time and help them to understand what's going on and what the appropriate management might be. When it comes to the more medical side of management, I think it is important to consider whether or not there might be reversible causes at work. Perhaps do some investigations if it's appropriate to do so, and work on whether or not you can reverse the delirium. We talked about opioid rotation in this patient. We talked about hydration in opioid toxicity or a dehydrated patient. And we talked about how the use of neuroleptics can be helpful to control the agitation and restlessness. But remember, important to use at least a small dose of something like haloperidol in the hypoactive delirious patient as well, because they tell us after their delirium clears, some of them, that hypoactive delirium is very distressing as well. Now I've got atypical neuroleptics on this slide, so I'm talking about drugs like olanzapine and risperidol, and some of us use those medications. Not a lot of evidence to say that they're effective, but they do have some benefits over the older ones. I'm not going to tell you here that there is benefit over haloperidol, for which there's the most literature to support its use. But I suspect we'll see increasing use of the atypicals over the coming years. Now, when I first gave this talk, sort of up until 6 or 12 months ago, the last bullet on this slide said benzodiazepines last resort, exclamation mark. And I've changed it more recently, last resort, question mark. I'm not as convinced as I once was that benzodiazepines may not have a role earlier on. Whereas I used to sort of wait until we had an agitated patient who had failed Haldol, Nozanan, and so on. Some of us in Calgary, at least, are starting to use midazolam very early on. Now, midazolam to control their agitation and restlessness, not to palliative sedate them. And I want to be very clear, and we find that we have to be very clear what our intent is. And the reason that midazolam may be helpful in some of these patients over Haldol or Nozanan is it works very quickly. You can very easily titrate it rapidly, and you can stop it and its effect wears off very quickly. So those of you in pharmacy and medicine may think about that sometime when you have a patient that appears to be, their restlessness and agitation is very, very distressing to all, and you want to get rapid control of it, and the first dose of Haldol or Nozanan or the first 2 or 3 doses don't seem to be working. Moving to midazolam earlier with the goal of reversing the delirium and then stopping the midazolam may have a role. I'm thinking about patients such as the one we had a while ago who threw his oxygen tank out of the 4th floor of the hospital window, and that type of thing. Some of these patients can be quite dangerous to themselves and others, so sometimes there are such scenarios. Well, I want to tell you the story of a second patient who has another lesson to teach us about delirium and palliative care. Mrs. D is also 68 years old. She has unresectable carcinoma of the pancreas, which was diagnosed 6 months before I was asked to see her. She was on gemcitabine, which is a palliative chemotherapy agent that was stopped about 6 weeks ago before I met her. She was known to have metastatic disease to her liver, and she had had a celiac plexus block about 3 months before. She was on a small dose of sustained-release morphine. She never needed any breakthrough, and she was on a bowel routine. Here was the issue. Over the previous 4 to 6 weeks or so, her family reported that she was less and less mobile. She had become bedridden over the past 2 weeks. She really hadn't eaten or drank anything. Her appetite had slowly decreased over the course of that time, and she was confused. She no longer seemed aware of what was going on around her. She didn't seem to interact with them except very occasionally to give one-word answers to questions. She took the occasional sips of fluid, but nothing else orally. And her family was concerned that she was confused and wondered whether there was anything that we could do about it. No, she didn't seem to be in any pain. She didn't have any complaints of any other symptoms. In fact, she seemed very comfortable. Well, I attempted to do a physical assessment. Her mini mental status exam was clearly abnormal. In fact, she couldn't complete it. It was 9 out of 24. She was extremely cachectic. She probably weighed about 30 kilos, profoundly cachectic. She really couldn't cooperate with any part of my physical examination. She had a huge mass in her upper abdomen, likely from massive liver metastases, but no neurological signs to suggest central nervous system metastases. And my question is, how should I manage this patient? She's dying. Quite right. And that's the most common answer I get when I ask this question. In fact, she is dying. Should we look for a cause for her delirium? Should we try to reverse her delirium? Should we offer this to her family as an option? Seeing a few people shaking their heads. Well, I think you're right to be cautious in such a situation. And here's why. If we take delirium in cancer patients, here's what we find. About 50% of the time, we can't find a cause. And if we can't find a cause, we probably can't help them to get better. We can manage their symptoms, we can educate and support their families, and so on, but we probably cannot reverse their delirium. Of the other 50%, about 2/3 or 1/3 overall, we can find a reversible cause. So that means overall in delirious cancer patients, we only have about a 1 out of 3 chance of finding something that we can fix. And that's important when we talk to their family members about what kind of treatment would be appropriate for them. The first example was one in which one could argue pretty suspicious that he had dehydration, opioid toxicity, and the chances of us reversing that delirium were very high. In this second case, I've deliberately made it quite obvious that she was much more likely suffering from what some might call a terminal delirium. So delirium at the very end of life, when, as you say, she's dying, and we would be unlikely, even if the family directed us to do so, to find a correctable cause for her delirium. So I often will draw a little pie chart like this for the family as I am talking to them, whether or not they have what I think is a reversible cause or an irreversible situation. I want consent to do what they think their family member would want, and I think this is an important part of getting informed consent. Any questions about that? It certainly adds to the challenge, doesn't it? And as I said, I've given you 2 case examples that are obviously one or the other. But it's not always so easy, and sometimes we have to give the family members that information and let them choose based on what they know of their loved one's wishes as to whether or not we should be pursuing efforts to reverse their delirium or simply manage them symptomatically and keep them comfortable. I want to just spend a few more minutes on this problem of distinguishing pain from the symptoms of delirium. It's often very, very challenging for all of us. So you have a delirious patient who's complaining of pain. How do you convince yourself, other people looking after the patient, and family members that the Haldol syringe might be more appropriate than the morphine syringe, as it were? And one of the first questions that I ask myself is, did the patient have pain before they became delirious? And if not, why should they have pain now? So if we go back to Mr. D, our first case, his pain was very well managed. He was delirious. Why would he have pain now when it was so well managed before? Now it could be that he developed a pathological fracture of his vertebral metastases. It could be that he was developing spinal cord compression. It could be that he developed yet another pain syndrome. All of those are possible, but when we looked, we couldn't find good evidence for that. He couldn't localize his pain. There wasn't particular pain over his spinous process, and so on. So a very useful question to ask at the outset. Other things that can be helpful to distinguish pain from the symptoms of delirium are the following. 1, the true pain is often more localized. So if your patient says, I have pain all over, it's much more likely to be delirium than if they say, you know, I have pain in my lower back and I can put my finger on it. Irritability, restlessness, problems with sleep, unfortunately, are not terribly specific. We need to recognize that people with pain can have those, as well as people with delirium. As well, grimacing, groaning, moaning can be to a pain syndrome, but I would argue that it's much more likely to be a delirious patient manifesting those symptoms. And finally, if I can localize that pain to a known pathology. So if they say, I have pain in my lower back, it's right here, and I know that on an x-ray there's metastases, that's a lot more convincing than, oh, I have pain here, and I've done a bone scan, or I've done an examination, or I've done other investigations, and there's no evidence that there's anything to be causing pain in that area. And then maybe the final thing is, if you give them analgesia and it seems to work, that's much more convincing that it's pain than if you give them more analgesia and it doesn't seem to be of any benefit. And conversely, if neuroleptics seem to help them and make them more comfortable, it's more likely that it's delirium that's at work than pain. So those are some of the things that I sometimes find helpful when I'm trying to distinguish whether it's true pain or whether it's delirium masquerading as pain. Let's move on to a few things about how we might think about preventing delirium in the patients that we see. And I've divided this into primary prevention, those things that we can do to avoid delirium developing in the patients that we see, and then secondary prevention, which is those patients that have developed delirium, how can we prevent them from suffering more as a result of it? So the first thing is, we should be vigilant, looking for things that might precipitate a delirium. Are they adequately oxygenated, adequately hydrated, evidence of electrolyte imbalance, infection, and so on. The second thing is that when we manage a person's pain or other symptoms, we always, in medicine anyway, we tend to think about the use of drugs. And we need to recognize that the adverse effects from these medications, particularly opioids, are very common. So we need to use them, but use them appropriately and use them sparingly. Think about other things that we could do that might be effective as adjuvants, things that we can add to opioids to decrease the amount that we might need. I've already mentioned the issue about benzodiazepines, but there are other medications that we use that can have an impact on a person's cognitive function. When you look at those patients who have developed delirium already, one of the things that might be helpful to avoid increasing distress would be to recognize it early. And I've talked about the use of something like a mini mental status exam or another screening tool to detect it early on. And then I've also talked about the use of effective non-pharmacological as well as medical management. So we've talked about how delirium is a common problem in the patients that we see. We've talked about how it causes distress for everyone involved. We've talked about how it's a burden on our healthcare system, how a confused patient becomes an unreliable patient when it comes to managing their other symptoms. We've talked about how it might be preventable in some cases, and certainly we can prevent some of the distress that is involved. And finally, how we need to work harder to recognize delirium in the patients that we see. There's one other point that I want to make about delirium, and this leads into our talk about palliative sedation, and that is that we found in Calgary that when delirium is not recognized or not managed effectively, there's some suggestion that it may lead to the inappropriate use of palliative sedation. So the question, I think, is for the management of delirious patients, I did not talk about alternative therapies such as therapeutic touch, Reiki, and other such complementary therapies. Was that the question? Thank you. I did not, and I don't know of evidence in that area, and I'm not familiar with, I've not had experience with those therapies in a delirious patient. Is there anyone else in the room with experience in Reiki or touch, therapeutic touch in confused delirious patients? Do you have experience in that area? And is it helpful in delirious patients? So in a preventive way, it can be helpful to decrease the amount of analgesia required and so on. And cause calmness, help calm the patient. Very good, thank you. I've not seen that done. I think anything that we can do, to, as I mentioned, to decrease the amount of analgesia required can be helpful in a preventative way. So the question is the use of a mini-mental status exam, and if we find that the patient's score has decreased below their baseline value, do we know that they have delirium? And the answer is that it's a screening tool. So like any other screening tool, it's not diagnostic. It is a tool that can alert us that delirium may be the problem. So when a person has an abnormal mini-mental status exam, it may be delirium, it may be dementia, it may be some other cognitive dysfunction. Now, if we know they had a normal baseline and it's an acute change, that immediately supports the case for delirium. But we need to go back and visit the patient and ask them about all those other features of delirium that we looked at. In our population, that is people with terminal illnesses, by far the most common cause of that decrease in the mini-mental status score is in fact delirium. Regarding methylphenidate, in hypoactive delirious patients, we certainly use it in those who we think depression is a significant problem. And we use methylphenidate in those people who are sedated from opioids but are otherwise managing very well. The use of methylphenidate in hypoactive delirious patients is something that I've tried on 2 occasions, and both cases the outcome was that I created a hyperactive delirium, and I didn't feel like I had served the patient very well. So I felt twice burned and have not gone back to that toolkit for hypoactive delirium again. Good question. So the question is, if I had a patient who had cognitive impairment from long-term alcohol abuse, would I treat them in the same way? The answer is probably no. I might try to use neuroleptics, Haldol and so on, if I needed to control their behavior. But unless they were also delirious, so from alcohol withdrawal or one of the other causes that we've talked about, I probably would try to avoid medications as much as possible, because I'm just going to add, even with Haldol, potentially add to their cognitive impairment. So their cognitive impairment for organic brain syndrome from alcohol or Alzheimer's disease or other forms of dementia is probably not going to be ameliorated by neuroleptics. The only proviso is if it's behavior I'm trying to control, or if they also become delirious, then I might consider that. And certainly delirium is a risk factor for these people because they have cognitive impairment to begin with.